Right, let's get going. Good evening, everyone, and welcome to the next of our series of webinars from OCL Vision. It's nice to meet you. My name is Purvi, one of the optometrists. Tonight's session is recorded, so for those of you who would like to watch it later, all our other webinars, plus this one, is available to view on our YouTube channel, OCL Vision. For those of you joining us today for the first time, a huge hello, and for those of you who are back again, it's nice to see you again. There is one CET point available for this webinar, and that's if you have logged in with the link that you received when you registered. This lecture will run for 45 minutes with questions at the end. So if you do have any questions, please feel free to pop them into the Q&A box at the bottom of the screen, and we'll get through as many as we can at the end of the lecture. So tonight's speaker is our very own Mr. Allon Barsam. Allon is director and founding partner of OCL and lead Corneal consultant ophthalmic surgeon at the L&D Hospital. He specialises in laser eye surgery, lens-based vision correction, complex cataract and anterior eye surgery. His laser eye surgery patients include elite military personnel, fighter pilots, professional athletes, as well as many doctors, optometrists and eye surgeons. It's going to be a great one. Allon, over to you.
Thanks very much for that kind introduction, and welcome everybody. Let me just get my slides up here. Okay, there we are. So I'm going to talk to you this evening about surgical solutions for presbyopia. These are my disclosures. So I'll talk a little bit about a background to presbyopia, or at least how we view it and think about it from a surgical perspective. I will try and talk you through all of the key surgical options and technology available today, along with some of the diagnostic modalities that are relevant. We will talk about complications and patient selection, and there should be time at the end for questions. It's a huge topic, so some of the slides I'll be going through quite quickly, and anything that isn't covered, you could either ask questions, or for any of you that have access to the AOP website, I put together a series of educational papers on various refractive error and the treatment options for them: myopia, hyperopia, astigmatism, and presbyopia. So a lot of the content, or at least the principles from this lecture, can be found there online. So you'll be familiar with this, which is essentially that there's a gradual decline in people's ability to focus at near point, which is presbyopia. And people have tried to tabulate it in a way that can give you some kind of idea of what you might expect. The key thing with this is, and you'll know this because you measure it yourselves on a regular basis, is that it varies hugely. So although obviously there is an association of these figures with the patient's individual age, some people have presbyopia quite early, some people have presbyopia quite late. It's obviously critical for us to measure it so we know what we need to treat and to anticipate what might need to be accounted for in the future, providing we are trying to give patients vision not just now but also in the future in terms of what they need. Our world has changed dramatically over the last 10 to 15 years. So in the past, people talked about kind of having fighter pilot vision for distance and being able to see far distance when you're driving. Now everything has become close. We're very close to having fully automated cars that are controlled via a computer screen. Fighter pilots are becoming very rare, and in fact drone operators are much more common now. Everyone's on mobile phones, and the ability to read close and potentially read unaided is important to many patients. I always like showing this picture, which I think is really helpful when we think about the interface between refractive surgery and optometric care. Basically, this is the clinical iceberg. It's to do with the small, tiny bit of ice that was unseen by the Titanic and ended up sinking the Titanic. But the principle is that what you see above the water does not represent everything that's below the water, and what you see in clinical care does not represent everything that's there. So fully aware that the majority of patients you see are really happy with glasses and contact lenses and will come to you, happily wear them. Whereas the majority of patients I see are unhappy with glasses and contact lenses, or they wouldn't be coming to me. And I suppose that this lecture really is aimed at the patients that fall in between that category, where they're not sure about whether they are or aren't happy in glasses or contact lenses, where they're exploring options, where they may ask you, what do you think about vision correction surgery, or are there any options for me not to wear glasses or contact lenses? Or you might know that they're starting to struggle with contact lenses, for example, and then this lecture should be applicable to them. And given that everyone becomes presbyopic, there are obviously an enormous number of potential patients that could be benefited from this technology, and from what I'm going to talk to you about. So first thing to say is correcting presbyopia is not a cosmetic thing. Patients, especially as they get older, really like the cosmetic appearance of their glasses. Many of them feel like it hides wrinkles, it complements their face, and glasses are becoming more and more fashionable. It's actually more of a lifestyle issue. Contact lenses themselves have their own risks, as you'll be aware of. There are distortions that you can get, especially from high prescriptions. And now with a pandemic, mask fog is a real thing. And although we're hoping that masks can be a thing of the past, in crowded areas like public transport and potentially aeroplanes, it's likely to be something that will stay with us for the foreseeable future. There's a lot of skepticism out there about the laser eye surgery industry, and I think a lot of it's warranted. And what's relevant to this talk is that in general, the high street are quite bad at counseling people with regards to presbyopia. So younger patients don't generally get told about what will happen in the future, and they often perceive that the distance prescription is wearing off when they become presbyopic, which is not the case. And then also having a kind of one size fits all where everyone gets one kind of technology or one kind of intervention or one kind of lens is not the best thing. All refractive surgery should be very bespoke, but especially presbyopia correction, as I hope this lecture will elucidate for you, is very customized. This slide just reminds us of the kind of interplay between technology and surgeon, and all of the surgery that you see now, whilst being heavily technology dependent, the success and safety of which is hugely influenced by the surgeon carrying it out. Presbyopia surgery also is of interest because it is not the case that all patients will benefit from just a laser presbyopia option, or all patients will benefit from a lens-based presbyopia option. It's very difficult to know, in fact, what will suit any given patient. Sometimes we give patients more than one option, depending on the conditions in their eye and the level of refractive error. But having a center, a clinic, and a surgeon that can accommodate all of the options is going to increase the chances that the most appropriate surgical solution will be found for that patient, should they so wish. This just reminds us of how important it is to look after our elderly patients. Some of our presbyopic patients are quite elderly, like this lady, just being taken for a walk there by a dog. And this reminds us that we can treat all refractive error and presbyopia with surgical intervention. So there is no amount of refractive error that we cannot treat. It's just that we don't treat all of it in the same way. So for laser, generally the parameters are, we would be unlikely to treat anything smaller than minus 0.75 unless we need to do it enhance one of our own patients. But minus 0.75 to minus 10 for myopia, up to plus 6 for hyperopia, up to 6 diopters of astigmatism, and then presbyopia, really it's the above parameters. But as patients become older, the threshold for doing laser becomes higher. So we're less likely to treat high hyperopia or high myopia in someone that is approaching cataract age range, because the precision and the risk profile changes. And I'll talk a bit more about that in a few minutes. There are a variety of options that you may have heard of. Many of them don't work, or people thought they worked, tried them, and then realized they didn't work. But essentially, laser options, and then intraocular lens options, which include phakic intraocular lenses, and then pseudophakia, which goes by a variety of different names. If they have a cataract, it's cataract surgery, but otherwise refractive lens exchange, also known as, people call it other things such as Prelex, New View, Claraview. It's all people just trying to brand the same operation. Excimer laser surgery is incredibly accurate, and many people don't realize is an option for treating presbyopia. Its precision, its safety, all give it some advantages over the lens-based options. It requires a variety of technology, femtosecond laser, Excimer laser, and a diagnostic platform, which is especially important in presbyopia correction, because wavefront scanning and a wavefront utilized treatment profile is what allows us to achieve some of the things we can achieve in presbyopia correction with laser. Essentially, this slide is just to remind you that the higher order aberrations, and the most important of which, for the purposes of this lecture, is spherical aberration, of which there are a variety of different orders of spherical aberration, depending on what kind of aberration profile you're looking at. You can generate, using a aberrometer, a point spread function, which simulates how point source of light would be handled by a given patient's optical system. And we can manipulate this and take advantage of this with some of our presbyopia correcting options. So nowadays, the wavefront optimized or wavefront guided laser vision correction profile will aim to maintain the natural prolate shape of the cornea. So rather than just a kind of abrupt tabletop shaving off of the cornea for a myopic treatment, there's a gradual tail off of the number of laser pulses and the amount of laser ablation that happens to maintain the natural shape of the cornea. But we can create a hyperprolate cornea where we exaggerate this in order to increase the depth of focus for presbyopia correction. Similarly, with hyperopia, there's this graduated change, which now results in large optical zones, good quality vision, and good quality night vision, which didn't used to exist before. Again, allows us to increase the limits of what we can do with presbyopia offering. The femtosecond laser is important for precision and rapid healing. The technology level of the Excimer laser is also of benefit because it gives us a greater degree of power to manipulate the shape that we achieve through laser vision correction, which is relevant for presbyopia. This just shows this in action. There's a infrared camera, so it's night vision, so we can deliver the treatment on the nighttime pupil if we need to. There's cyclotorsional control, so we will account for any rotation of the globe that happens when people lie down, so we can deliver an accurate astigmatism correction. And presbyopia patients are actually, their tolerability for residual refractive error is very low, i.e. it's very important to totally nail the refractive aim for the dominant and the non-dominant eye in order to achieve what we're trying to achieve. So a lot of the technological adaptations that are routine now with younger pre-presbyopic distance LASIK are all as important, if not more, in presbyopic LASIK. And these kind of the tightness of attempted versus achieved refractive correction right up until -10 myopia is again very useful in presbyopia correction, because we're relying on each eye to achieve its aim individually, which is not the case when you're treating the two eyes in exactly the same way, and it can be a bit more forgiving of refractive error in one of your eyes. There's been a huge amount of research to look at safety of laser vision correction. I'm not going to go into too much of this, but tens of thousands of patients have been studied now. But despite that, complications can occur. Many complications occur because of poor patient selection. So there are many patients that shouldn't have laser vision correction, and there are places where there's a very high pressure to put patients through for surgery, even if it wouldn't be the best thing for them, and they often end up with problems. But then many problems are actually manageable, but again, not always well managed, depending on which clinics patients are going to. So significant problems from laser eye surgery are exceptionally rare, providing patients are well selected. Any problems are managed afterwards, but it's not zero. And again, patients are all told about these risks in detail at their first consultation. The risks are unique to each individual patient. It's not the same for one person to another. You've probably heard of SMILE. We can't really use SMILE for the presbyopia laser vision correction because it doesn't have the ability to create that subtle change in the corneal profile. It's not as accurate in terms of treating astigmatism. There are other generations of SMILE or SMILE alternatives around the corner, which we'll hopefully be able to tell you about towards the end of the year. So monovision, you likely be familiar with this. You may have even tried it with some of your patients who are presbyopic and wearing contact lenses, and it's still a really great treatment. It has advantages. and some disadvantages. The advantages obviously are relative independence of glasses and contact lenses. The disadvantages that if you're trying to do an offset of more than one diopter, they can suffer from anisometropia, and they can also be a loss of stereopsis. Laser blended vision. It's one of the many terms that are kind of banded around within the industry, which can be a bit confusing. Essentially, what it's characterized by is the ability to increase depth of focus beyond what you'd be able to achieve just with glasses or with a contact lens. And that occurs due to the controlled induction of spherical aberration, which can be done only in the non-dominant eye, in the dominant eye and the non-dominant eye, depending on surgeon preference. And I'll again talk to you a bit more about this in a second, but it essentially means that patients can tolerate more any disparity in the refractive measurement of the individual eyes. The one that we use is Presbymax, and actually we do more of this than anyone else in the UK. And essentially it's described as a biaspheric, I don't like this term, multifocal ablation profile. It's more like a hyperprolate corneal shape. So it increases the curvature centrally, which it causes controlled spherical aberration and increased depth of focus. We can modify the extent to which we do this. So we have a variety of different options in terms of how much of this to induce in a patient's eye, depending on their requirement for close reading, depending on their age, depending on the addition, depending on what they want to achieve from surgery. Some people are quite happy wearing reading glasses, in which case it may not be a good option for them. Some people just want social reading but don't need small print reading. So again, we go through this with patients, and our aim is not to make patients totally independent of glasses. Our aim is to make patients happy, which sometimes requires total independence of glasses, but not always. So we try and work out what it is they want, what it is they need, and then aim to deliver that. And this Presbymax treatment aims to deliberately leave them a little bit myopic in the non-dominant eye and makes the cornea hyperprolate or more steep in the center. And I don't drive any deliberate aberration into the dominant eye. I like my patients to have the best vision possible in their dominant eye. And so this only happens in the non-dominant eye. The dominant eye just gets a standard distance LASIK treatment. Again, it defaults to minus 0.89, but actually I will fudge the refraction and I target minus 1.19. So the refractive error is normally minus 1.19 in the non-dominant eye. And then they have an increased depth of focus of approximately 1.5 diopters on top of that, which allows them to read small print should they so wish. This is how the ablation profile would look. So the red is kind of like amount of pulses or amount of cornea ablated. This is how it would look if you were treating zero refractive error. But essentially you can see pulses in the kind of mid periphery, and then that's basically nothing happening in the center. So the cornea is being artificially steepened in the center in the non-dominant eye in order to increase the depth of focus. That's how it works. We have to know what the dominant eye is, what the non-dominant eye is, and we test that when they come into clinic. And the hyperopia, this just shows you a hyperopic profile in the dominant eye, which is just a standard hyperopic profile. Now, this is hyperopic treatment with Presbymax in the non-dominant eye. So it looks very similar, only you might feel that the optical zone is smaller, but essentially it is trying to just make the cornea steeper in the center. And I'll show you an example of this in a second. Nice feature on our laser is that there's a reversal option. So in the unlikely event that anyone has a quality of vision issue, we can actually lift the flap, hit reversal, and put them back to totally normal corneal shape. I've not had to do that for any of my patients, but it's comforting to know that we could if we needed to. So in terms of our evaluation in clinic, we do a standard laser eye surgery evaluation. Binocularity is very important. If they're not binocular, we would have a concern about their ability to tolerate laser blended vision or Presbymax. We want to know what the reading addition is. We do a loose lens test, so we flick up a +1 lens over the non-dominant eye and just check what their reaction is. We know they won't like it necessarily, but it's the extent to which they are aware of it. It gives us a little bit of indication as to how fussy they are with respect to their vision. We don't find contact lens trials to be particularly useful, with a rare exception. Obviously, if they come having tolerated monovision in a contact lens and then are no longer tolerating contact lenses from a comfort point of view, then that's helpful. But because this increases the depth of focus in a way that contact lenses don't, because we advise patients that it takes 6 to 12 weeks to adapt and adjust, patients would have to tolerate a contact lens trial for a long time to really know if it was going to be of benefit to them. But for those that are very unsure, maybe the emmetropes, we sometimes recommend this or advise them to do it. We still tell patients there's about a 1 in 30 chance that they will want a pair of glasses for nighttime driving. Nighttime driving is very visually demanding. Long distance driving when the conditions are poor, difficult for anyone, but for presbyopic patients especially. So if they have that problem, well, they're always told beforehand that might be a requirement for them. They're also told beforehand the same thing that all presbyopic patients are told, which is that there's no surgical solution that gives them the vision that they had when they were 20, if they can imagine wearing glasses or contact lenses at that age, i.e. every single surgical and non-surgical option, which includes glasses and contact lens wearing requires some kind of compromise, and the job for them and for us is to try and find the most appropriate compromise for them. Some people might feel their most appropriate compromise is to continue wearing glasses or contact lenses. Others will accept the other compromises, which include 1 in 30 chances of wearing glasses at night for driving occasionally, and a 6 to 12 week adaptation period. But it is highly effective. So the cumulative distance vision, this is just a small sample, 16 patients, but this is logMAR vision, so that's 6/5 here, 90% at 6/5 or better, 100% at 6/6 or better, and 40% at 6/4 or better. If we were treating only distance, this number would be much higher. So my own results for distance LASIK, something like 88% at 6/4 or better binocularly. But obviously, because we're doing other treatment in the non-dominant eye, that reduces a little bit, but it is imperceptible to them. And what they want is independence of glass and contact lenses in many cases. And the near vision, this is about N6 here. This is N4 to N5 here. So 80 to 90% at N4, N5. And pretty much everyone is better than N8. So everyone has social reading and almost everyone has small print reading. And we don't always target small print reading, so it does depend to some extent on what we're targeting and what they want. This is an example. This is a 62-year-old consultant physician. He was treated somewhere else 18 years ago with myopic LASIK. He never had really sharp vision afterwards. I think 18 years ago, LASIK isn't what it is now, and also not all providers were able to achieve emmetropia. But in any case, he's now bothered not only by the fact that he's distance glasses dependent, but also reading glasses dependent. And sometimes the glasses are on, sometimes they're off, etc., etc. And he's a little bit myopic. So we did an OCT scan, which measured his original flap at 165 microns. That gives us information, namely that there is room to safely create a new flap within his existing flap. This is something that I'm about to publish on, actually. I have a series of several patients we've treated in this fashion. We can create a new flap at 100 microns. This is his left non-dominant eye. You can see pretty much normal corneal shape with the rule astigmatism. And we did a Presbymax treatment, a presbyopic laser vision correction treatment. Again, is a non-dominant eye, target fudge refraction minus 1.19 with the extra depth of focus at 1.5 diopters. And this is what he is post-operatively. The dominant eye was just treated with standard distance LASIK, so 6/5, N5 binocularly. And then you can see on his corneal shape here, the center of the cornea is just a little bit steeper than the mid-periphery. So center of cornea here, 41 diopters, mid-periphery about 40 diopters. So that subtle change in corneal shape is what induces controlled spherical aberration, increased depth of focus, and makes the vision more natural to them. We can measure it using our aberrometer afterwards. Phakic intraocular lens, I'm going to whip through this. There's a very tiny subgroup of pre-presbyopic or early presbyopic patients who are young enough to have phakic intraocular lenses, have healthy, natural intraocular lenses, and where we feel that refractive lens exchange would be too interventional for them, namely patients in their late 40s, maybe early 50s. I don't use presbyopic phakic IOLs. I use a standard distance monofocal phakic intraocular lenses, and then we'll just target a little bit of myopia in the non-dominant eye. But again, I've only done this on a handful of patients, but it is an option. It's the mainstay of treatment is in the high prescription, so high refractive error. But phakic intraocular lens surgery is safer than refractive lens exchange, because there's less risk of inducing early retinal detachment and less risk of infection and other such problems. The indications are high refractive error normally, but also patients have form-fruit keratoconus, where we don't feel that laser vision correction is a good option, and dry eye, again, where we wouldn't do laser vision correction. But and now I'm going to get on to talking about refractive lens exchange surgery with premium intraocular lenses. Everything in this section is also applicable if someone has a cataract. Only if they have a cataract, then the indication for surgery or the motivation for surgery is different, because they have disease that requires treatment, and then the discussion really is about what kind of lens they might want. Whereas again, refractive lens exchange surgery is an alternative to glasses and contact lens wear that a patient may or may not feel is of benefit to them. So we would do this on patients not suitable for laser eye surgery or phakic intraocular lenses. I've put age over 45 for high hyperopes, but I rarely will do this in patients under 50, even if they are high hyperopes. Occasionally, if they're 48, 49, and they're +7, +8, +9 of hyperopia, then I will use that treatment. Mostly they have to be over 50, because I believe that they need to be closer to cataract age range to justify the risks of refractive lens exchange surgery. Important here, it's technically identical to cataract surgery, but it's done by refractive surgeons. Many cataract surgeons who are not refractive surgeons think they can do refractive lens exchange, but actually they need to be indemnified for that. There's a lot of workup and aftercare that's required, and it's quite easy to get it wrong. Even if you technically carry out the surgery well, if you use the wrong intervention or don't quite understand which patients may or may not benefit from it, then it can be a difficult problem to deal with afterwards. So really, refractive lens exchange surgery should be done by refractive surgeons. Ideally, refractive surgeons who also do cataract surgery, because it's a similar skill. So femtosecond is the adjunct now that we like to use during refractive lens exchange surgery. We get an OCT image of the whole eye and can do the capsulotomy, if need be, the corneal incisions, and divide the lens, all with the femtosecond laser. We can center it, it's all drag and drop. I'll just show you the capsulotomy being made in a second. And there we go. You see bubbles being formed here in the capsulotomy, but it's, it creates a perfectly round, well-centered capsulotomy. Now it's here dividing the lens. There are a variety of potential advantages to femtosecond laser-assisted cataract or refractive lens exchange surgery. Not all of them have been proven. So more efficient lens disruption removal, not really. More precise and accurate cataract incision, I don't think so. But it does generate a more precise and accurate capsulotomy, which can have a small bearing on the refractive outcome. And then we can also use it for relaxing incisions if we're not using a toric intraocular lens. You don't see capsular phimosis after femtosecond RLE or cataract surgery. Not that you see it very commonly after manual cataract or RLE surgery, but it does guarantee that you get an optimal sized and centered capsulotomy, which can have an impact on the final refraction. Treating astigmatism is essential in patients that want to be independent of glasses. The level of astigmatism is highly related to their likelihood of needing glasses. So we treat it aggressively. Small amounts of astigmatism we'll treat with a low power toric intraocular lens, or if it's very low, we can do limbal relaxing incisions, which still work quite well, depending on which kind of lens we're using. But the lens has to be aligned to the steep axis of the cornea. This is just a video just to show. I'm not going to show the whole video, but you'll just see there's ink marks that you see at the beginning. We mark here, and the lens is just lined up at the end. You'll see little marks here where the lens is, and that just basically the toric markers on this lens line up with the cornea there. Let me jump to the next. Now, there's a variety of different terminology that can be used to describe how lenses work, and they're a bit confusing. Some of it, again, is industry driven. And so what I want to do during this talk is try and use the terminology that describes how the lenses work, rather than what industry want a lens to be called. So the single focus you'll be familiar with, monofocal lens. That's the standard kind of lens used in the NHS, for example. And then there are lenses that do a bit more than that. So there's increased range of focus. Some people were using the term extended depth of focus, which is quite confusing, because all premium lenses extend the depth of focus if they're trying to correct presbyopia. But increased range of focus is a more useful term. And then full range of focus is things like a trifocal lens that is trying to give you vision at all distances. The multifocal lenses of 10 or 15 years ago were bifocal, and didn't really get a good reputation because bifocal vision is quite unnatural. So what's come along recently, well, not recently, but over the last 5 or 10 years, has become much more popular, are trifocal lenses, which are basically two bifocal designs overlaid on each other. So distance and near, distance and intermediate gives you a trifocal lens, which is distance, intermediate, and near. And by filling in that intermediate area, this is the defocus profile. So bifocal lens, you can see they do well at near, quite well for reading, but there's pretty much nothing for intermediate. Whereas a trifocal lens gives you the near, so the distance, intermediate, and near, and that more closely simulates natural vision. There are a variety of different trifocal lenses. I actually use two main types. Both of them are good for everything, but one is slightly better for intermediate, one is slightly better for reading. And I sometimes ask a patient what is their preference, and we'll then target the lens and customize the lens depending on the answer they give. There are a variety of simulators designed to try and show you how a patient would perceive trifocal vision. This is a very kind simulator that I think probably underestimates how they would perceive their nighttime vision after trifocal lenses. And this is probably an unkind illustration of extreme glare and halos that a patient might suffer from. And I think that the reality of what a patient sees is likely to be somewhere in the middle of these two, but they certainly need to be counseled that the compromise that they'll be accepting if they do want a trifocal lens is that they will have halos around lights at night, which are permanent. They generally don't stop people being able to do things. But if the rest of the optical system isn't optimized, then patients are highly symptomatic. So this lens option is quite an uncompromising lens option and requires more aftercare than a standard lens, because patients are intolerant of anything that isn't right with their visual system afterwards. Again, I've, as it happens, written book chapters on this subject, but I talk about the 7 C's, but essentially corneal and ocular surface disease. So if the eye's dry, that's going to be a problem for them. Centration, lens has to be well centered. So again, that the femtosecond capsulotomy becomes of use there. Cylinder and residual refractive error, they do not tolerate that. So a surgeon has to be willing to do a laser enhancement if they have any of that residually. Capsular opacification, they're very sensitive to that. So be prepared to do capsulotomy. If they get any kind of macular problems, obviously if that's pre-existing beforehand, we just wouldn't offer them a trifocal lens. Consecutive treatment, so in general, they don't do so well when it's just one eye treated. It's better to treat bilaterally. And then counseling, so all of this has to be explained before rather than after. And for that reason, in my cataract population of patients, I probably use trifocal lenses, I would say, in less than 20%. Many of them are totally happy in glasses and contact lenses, so I'm not going to get into all of this with them. But in refractive lens exchange patients who are really coming often to be independent of glasses and contact lenses, then this goes up to about 50 to 60%, maybe 70% maximum. But there's still a huge chunk of my refractive lens exchange patients that are not getting trifocal lenses. And the vast majority of my cataract patients are not getting trifocal lenses. So who do we avoid and why? Well, people that demand total spectacle independence, not because we can't achieve it, but just because they're often, they can be the least reasonable of patients. If they've got ocular surface disease that we don't think we're going to be able to easily treat, severe ocular surface disease, that can be a problem. Obviously, that means ocular surface disease not due to contact lenses, because if that's the case, they can just refrain from contact lens wear, which will be the case after surgery. Irregular corneal astigmatism, macular pathology, high corneal astigmatism, concerns over lens centration such as pseudoexfoliation syndrome, glaucoma, and then corneal disease such as Fuchs. So actually, if you look at patients over the age of 80, quite a lot of them actually fit into that category, which is probably another reason why I don't put this in the majority of my cataract patients, but refractive lens exchange, not such a problem. Interestingly, if they develop these problems afterwards, they often are not symptomatic, but I think if you do it at the time, it can be more of a problem for them. So combining all of these technologies, again, I'm not going to play the full video just because of time, but this was actually the first implantation of the Rayner trifocal toric. Again, so it's femtosecond capsulotomy, lens division. We've marked the toric area already. We can just remove the capsule there, and the lens goes in there, and you just see it. And we need to just obviously dial it around so that it lines up with the ink marks and centers well. So increased range of focus lenses. Well, the first one to come out was this lens called the Symphony lens, which was marketed as an extended depth of focus lens. Very misleading. Basically, it uses exactly the same diffractive optics as a trifocal lens, just with lower add power. So it has many of the same considerations, just achieves less and probably without much benefit. So don't use it very often at all. This is a true extended depth of focus lens, but again, it fits into the increased range of focus category. It's a small aperture lens. Again, it does cause dysphotopsia in some patients, so I tend to only use it in radial keratotomy patients where there aren't that many other good options for visual correction, given the many problems that those patients get. So on to kind of what's now we might call premium monofocal, but they are all increased range of focus lenses. They all give you more intermediate and a bit of reading vision, more than you'd expect just with a standard monofocal lens. And although patients might say, oh, I don't mind wearing reading glasses, that may be the case, but some patients are really annoyed if they can't see the dashboard of their car, can't see their phone, can't see their watch, can't see to shave or put on makeup. So these lenses kind of address that. They're not as expensive, but they are also not available in the NHS. So the softer version is the eye-enhanced lens, and then the more effective version, which does a bit more, is the Ray 1 EMV lens. But both of them give you better intermediate vision than you would have otherwise, and the Ray 1 EMV can give you a bit of reading too. We have more experience than anyone else in the world with the Ray 1 EMV because we put the very first one in 11 months ago. And essentially the principle is very similar to what I've explained with presbyopic laser, but this lens induces controlled small amounts of positive spherical aberration, which increases the depth of focus, and it gives about an extra diopter to diopter of 1.5 of increased depth of focus. And we can measure that. So this is our point spread function. We can see it here. It's not just a point of light. It has elongated the point spread function, it has elongated the wavefront, and it's inducing, according to this, 0.11 diopter equivalent of positive spherical aberration, a very small amount, but enough to account for how patients are able to read. We have analyzed this a bit more meaningfully. So the cumulative binocular uncorrected distance vision is, as you would expect, good, because it doesn't really do much to reduce that. So we have logMAR of 0, which is 6.6 vision, 80%, and almost everyone is 6.75 or more, and everyone is a driving standard of 6/9 or better. Let me just move this and move on. And the intermediate vision is excellent, and that's really what this lens is all about. Social reading, I call it, and it's the things that I just mentioned that patients find annoying if they don't have afterwards, even if they're not aware of it. So you can see here, everyone's N10 or more, but almost everyone is N8, and many are N6, and some are even N5, and that's with an emmetropic target. The benefit of this lens is we can target tiny amounts of myopia in the non-dominant eye, mini monovision. Minus 0.37 is actually what I normally go for. And then we can give them an extra line or two of intermediate vision. They still are going to need to go back to you for their prescription reading glasses. But it means that on the go and from day to day, they are not reliant on varifocals, which is what many of our patients are asking for. And then the near vision, pretty good too, 60% N6. This is a patient where we targeted monovision, so it was already tolerating monovision in contact lenses before, and we targeted, I believe, -1 in the non-dominant eye, and she achieved 6.4 N4 unaided. So again, we can push more if we want, but then you have the other issues with monovision, stereopsis. And also the chance of needing an enhancement is higher if you go for bigger amounts of monovision, because they're less tolerant of any refractive error, either in the dominant or the non-dominant eye. So in general, I like to go for lower amounts. And if they want total spectacle independence, we talk more about trifocal lenses when it's a refractive lens exchange patient. Complications are much more significant than laser vision correction, because with laser vision correction, the worst case scenario can be fixed, but you cannot fix endophthalmitis or intraocular hemorrhage. Fortunately, it's exceptionally rare. So we tell them there's a 1 in 2,000 chance of that. There's about a 1% chance of macular edema, 1 or 2% refractive surprise, more if we're targeting monovision. Maybe it would be 3 or 4%, 3% probably more likely. Ocular surface disease can be made worse. They can have inflammation afterwards. 1 in 10 posterior capsular opacification. These risks are acceptable to presbyopes who are not eligible for laser vision correction or laser blended vision, because they know that when they get into their 60s, there's a 60% chance they'll have a cataract, and that when they're 80, there's a 100% chance they'll have a cataract. So what they're doing is they're accepting surgical risk earlier in their life to have additional years where they do not need glasses, which is what some of them want. So that's basically what makes the risks acceptable to them. The ones that elect to have the surgery, that is. Capsular opacification, the only consideration here is when you break the posterior capsule with a laser, if you were ever considering exchanging the lens because the patient's unhappy with their vision, then it becomes technically more difficult to do. So often this is the last thing that we'll do when we're confident that a patient is actually happy with their vision. But in about 1% of trifocal patients never adapt and adjust, or we just know early on that they're not going to because of how they perceive their vision and they behave, and other things, all other parameters that are controllable being normal, then we can do a lens exchange if need be. And I'll do, on my own patients, I'll do this maybe once every 2 or 3 years. It's really not very commonly required if you select patients well. But if it needs to be done, it can be done. Patient selection is really important. Patients don't know what's best for them. And with all respect, you as optometrists, in terms of the actual surgical intervention for presbyopia, also wouldn't, because we need to look at a variety of things that we specifically measure in clinic. And even then it can be difficult to know what the right thing is for them. So I think, the discussion, if they are to ask you, is really, look, there are a variety of options, and you just need to go and see someone who can go through it with you and try and work out what would be best for you and what wouldn't. And we actually turn away a lot of patients. If we don't think that they're going to be, that it's going to be a benefit for them, then we'll say no. We know that this is elective surgery, and we have no interest in generating results that are anything other than excellent for our patients. I think the optimal role varies. I mean, obviously we have, probably can speak to you more about shared care and things that we do, but I think the minimum is really to identify patients that are motivated to be independent of glasses and contact lenses. When they ask you the question, what do you think of laser eye surgery, or is there a surgical option, so I don't need to wear glasses or contact lenses, they may have already made up their mind they're going to go and see someone about it, and it gives you an opportunity to direct them to someone or to a clinic that you trust. And that is a critical part of the role, because there are people out there that are a little unscrupulous with respect to the manner in which they carry out surgery, who they do the surgery on, and then how they deal with it. We've been through this. Patients' lifestyle, their occupation is critical. We go through all this with patients. I even sometimes ask patients to show me where they read, because people will read at different distances. So the way we measure them in clinic doesn't always give us the information we need, but we want to know as much about them as possible. So in summary, we've gone through a background to presbyopia vision correction surgery, gone through a variety of surgical options and technology available, some diagnostic modalities. I've talked to you about some of the complications and patient selection criteria, and hopefully I've left plenty of time for questions. I want to thank, first of all, the incredible team at OCL Vision, including Purvi, who puts together these amazing webinars and actually put together a lot of the research data I presented to you tonight. But without this amazing team behind us, we wouldn't be able to do any of this stuff. And then always my family, who allowed me to miss bath time tonight so that I can be trying to teach you. Thank you.
Allon, thank you so much. That was...
Muted, Purvi.
I'm muted. Am I muted? Shouldn't
I
be.
don't know. Sorry, I'm muted.
That's fine. Could you just stop your screen share if that's okay? We've got a few questions to get through if you're ready.
Yeah.
Okay, in terms of laser, why do hypermetropic laser corrections regress?
The first thing is they don't all regress. The higher ones regress more commonly, and there are a variety of reasons in no particular order. Some of them regress because there's an element of latent hyperopia which was never picked up initially. So what we do, especially on patients that are younger hyperopes, is we'll actually give them cyclopentolate to try and fully paralyze accommodation, and we then deliver our treatment on the fully paralyzed kind of non-accommodative state, if you like. So we treat the full amount of hyperopia that is manifest, which sometimes means that they perceive myopia for weeks afterwards, and we'll then handhold them during that period, because we would rather have that than that they regress 2 years later. We're not trying to create a wow effect now and for them to come back in 2 years and go, what about my +2? So that's one big reason. Another reason is that the laser is carrying out most of its work in the peripheral, mid-periphery of the cornea, which is more prone to healing. So stromal remodeling, epithelial hyperplasia, all of the things that happen after laser vision correction procedure happen in a more profound and slightly less predictable fashion in hyperopia than in myopia. So that's why, those two reasons is why you sometimes see regression afterwards, but not always.
Thanks, Alan. I've got a couple of questions on the Presbymax, actually. You did answer one of these during your talk, but what happens if patients can't tolerate new visual conditions?
If they can't tolerate new visual conditions?
For example, if we had Presbymax, if we get monovision, what do we do if they just don't like it?
You mean if we do the surgery and they're then not happy afterwards?
Yes.
Well, it's quite rare. So we do test them in clinic beforehand to get a feel for whether we think they're likely to be happy or not. It's not common, but it's not uncommon for patients to take longer to neuroadapt in some cases. So 6 to 12 weeks is what we say, but some people take a bit longer. But often people assume that patients aren't tolerating something when they haven't looked at, is there a treatable cause of the fact they're not tolerating something? Do they have a bit of residual refractive error? Has their dominant eye been fully optimized? Has their non-dominant eye over or under corrected? Have they got a bit of residual astigmatism? Is their ocular surface poor? So we optimize and treat all of these things. If all of those things are made perfect and they still don't adapt and adjust and they complain, then we might give them a contact lens trial to see, would they prefer to have slightly less reading vision but better quality of vision? So we're removing quantity and giving them quality, and then we can partially enhance them to remove some of the myopia, and then very rarely we can reverse it totally and just give them distance vision, and then they'll wear reading glasses. But I've only ever had to do that on one patient in many, many years of doing this, and about 20% of all of the laser vision correction I do is presbyopic LASIK. So I'm doing treatments like this every week.
Alan, can Presbymax be done successfully on patients with moderate or high CILs?
Yes. You know, one of the nice things about Presbymax and presbyopic LASIK is that it is so precise and accurate at treating refractive error, even sometimes high refractive error. So, you know, the kind of things that would exclude patients is more, you know, the quality of the ocular surface, age, and yes, we do look at the refractive error. So if we had, let's say, a 63-year-old with, you know, 4.5 diopters or more of, you know, cylindrical error, refractive cylindrical error, and ocular surface that was a bit dodgy, we would probably prefer to do a monovision treatment with toric intraocular lenses rather than laser vision correction. But the refractive error alone is not what stops us, if that makes sense.
It does. Alan, does Presbymax work for amblyopic patients?
No. So if they're amblyopic, they cannot have Presbymax. If they're amblyopic, they can either accept distance vision, or they can have refractive lens exchange with trifocal lenses. We've done that on many amblyopes. So it works really well with amblyopes, but they have to be old enough to justify the risks of that. And
the last question on Presbymax, I mean, how successful is blended vision, you know, including Presbymax? Or
our satisfaction levels are really high. I would say they're some of our happiest patients, and actually they're quite stunned and astounded by it, because I think there's very little that's known about it out there. So I think that many patients don't realize you can do laser vision correction for reading vision. And actually many optometrists don't realize you can do laser vision correction for reading vision. One of the reasons for that is it's just not offered on the high street. They don't have that. It's not straightforward. You know, it is more demanding. It is more uncompromising. It requires more chair time, more discussion with patients, more measurements before, more work afterwards. You know, it's much easier for us to just do a 25-year-old -2 myope. But I think that the ability to deliver these kind of treatments safely and effectively is a bit of a discriminator, and certainly makes us better at all that other stuff as well.
How limiting is a small pupil size? I mean, with this, it's probably Presbymax and or trifocals.
So a small pupil size, I would say a very small pupil size is probably more of a problem with trifocal refractive lens exchange than it is with presbyopic LASIK, because we can totally control the optical zone. So we can go much smaller on the optical zone for presbyopic LASIK if we need to. And the small pupil will generally give that patient increased depth of focus or pseudo accommodation. So it will give them a benefit or an advantage with respect to their ability to read. If they have quite small pupils, the problem with trifocal lenses is that the pupil may not dilate sufficiently to actually allow the additional rings to work. So they only end up with distance vision and no reading. So although the lenses are all marketed as being pupil independent, none of them are totally pupil independent.
And how about if a patient has very dry eyes, can they still have surgery?
It depends on the cause of the dry eye. If they have hyposecretive dry eye, we might try first a course of steroid and icurvis or cyclosporin to try and stimulate tear production. But most commonly, patients have evaporative dry eye due to meibomian gland dysfunction, which we know to be treatable. So if it's moderate or good going, we'll treat it and then bring them back. If it's mild to moderate, we'll just treat it and go ahead and then give them the treatment, knowing that they will improve.
What is the best time to perform the corrective surgery in terms of what level of presbyopia do you think? I think it's time now.
Yeah, that's a great question. And it's something that I omitted in my talk, this whole concept, because there are so many factors that make patients suitable or not suitable for surgery. But in my opinion, the greatest suitability factor for presbyopic surgery is the level of dissatisfaction with patients reliant on glasses and contact lenses. So there is no age when they should have it, and there is no absolute cutoff for what we can and can't do, what we should and shouldn't do. But patients really hating glasses and contact lenses is a hugely positive indicator they're likely to benefit from surgery, because all of the options that I've explained require some kind of visual compromise. Nothing gives them perfectly natural vision. So if they're quite happy in glasses and contact lenses, definitely they should wait, because you know that the fact they've just started noticing they have to hold things a bit further away, that might be annoying for them, but it's not a major problem. It's when they're really, if you excuse my language, pissed off with it, that they're more likely to benefit from the surgery. So it's not so much the age, it's more how genuinely bothered they are by the need for wearing glasses and contact lenses. And the more bothered they are, the more likely they are to be suitable for surgery.
Excellent. Is it possible to correct corneal astigmatism with RLE?
Yes, it absolutely is. We can do that with toric intraocular lenses. We can do that with toric trifocal intraocular lenses. We can do it with limbal relaxing incisions combined with increased range of focus lenses. And there are also toric increased range of focus lenses. And if we're not able to fully correct it because patients end up with some residual refractive error after refractive lens exchange, then they can have bioptics, which is where we do laser vision correction afterwards to correct any residual cylinder or cylindrical refractive error.
Just going to go for a few more. Acutely, we're approaching 8 o'clock. Alan, how would you treat an RK patient whose vision fluctuates throughout the day?
Yeah, it's so difficult, and I feel so bad for these patients. That's why I like the IC8 lens. So that lens, that small aperture kind of pinhole lens, if you like, gives about 2 diopters of increased depth of focus. So, but because it gives 2 diopters of increased depth of focus, that means in theory, if you can get close to emmetropia with that lens, then it gives you a bit of leeway for some of that diurnal fluctuation, which is generally not huge, but significant enough to make their vision blurry on occasion. So that's my mainstay of treatment. I know people talk about putting sutures into the cornea and cross-linking, and you know, if they were very young, maybe I'd think about cross-linking, but if they're anywhere near presbyopic age range, which almost all of them are because radial keratotomy became obsolete so long ago, then I'd rather use an intraocular lens, leave the cornea alone, which is already unstable and unpredictable. And I would use the IC8 lens in the non-dominant eye, and in the dominant eye, I use the eye-enhanced lens, which is that kind of softer increased range of focus lens.
Thanks, Allon. How do you establish ocular dominance apart from the loose lens +1 blur test that you discussed?
You can probably answer that question better than I can, Purvi. Well, we have exceptional optometrists that do a lot of these measurements for us, but we ask them. We can do it with line of sight. We basically ask them to make a little triangle, or we have a card that they can look through, see which eye they go towards, and then we also put a +1 lens over what we perceive to be the non-dominant eye. Or we see which eye they prefer having the +1 lens over to know which is the non-dominant eye.
Allon, you talked about lens choice when a patient has systemic disease, and someone's asking, with a type 1 diabetic, would you consider IOLs, trifocal IOLs? How about if they have some background retinopathy?
Other surgeons do. I don't like it. I just know that their chance of cystoid macular edema is greater. It depends. If they were really desperate to be totally independent of glass and contact lenses, and they had a lot of problems with glass and contact lenses because of whatever their lifestyle needs are and what they happen to do, and the macula was totally pristine and normal, I would counsel them about the risks and that fact it might be a problem and might consider doing it. But I can't remember putting a trifocal lens into a type 1 diabetic anytime over the last few years. I'm not very aggressive with the use of trifocal lenses, let's put it that way.
We've just got a couple more, actually, if that's okay.
Yeah.
Someone just briefly asked about parameters for laser vision correction. So residual bed, how much you need to leave, thickness of cornea. Can you give us a quick summary of that at all?
Yeah, so we leave a residual stromal bed of 300 microns. The corneal thickness needs to be 490 microns or more. Occasionally we might go a tiny bit below that, as in 487, 488, if all other parameters are totally normal and it's a tiny amount of correction we're doing. And then we look carefully at dry eye, and then there's the amount of myopia as well that we're trying to treat. So we generally don't go more than -10, but the higher the amount of myopia, the thicker we want their cornea to be. The younger their age, the higher the alert level is for potentially offering them an ICL or phakic intraocular lens rather than laser vision correction. But there's a huge amount of a variety of parameters. Many people use 250 microns as a residual stromal bed, so we kind of built in a 50 micron cushion above that already.
Last question is a little bit of an interesting one. Occasionally, and very occasionally, you'll get some people, young patients, who come with quite a high ad in there, who need quite a high ad to achieve N5. So they might be 50 and they're needing a really high ad for their age. What do you think about prescribing glasses or, giving someone a high ad at such a young age?
I don't have a problem with that. Yeah, I don't have a problem with that. Presbyopia does vary. So that was the beginning bit of my talk. Maybe some people may have missed it, but essentially, you've got this table of what you expect the ad requirement to be dependent on age. But some people get significant presbyopia happening much earlier in their life, and if they need the ad and they tolerate it in glasses, that's totally fine. It's not bad for them. It's fine.
Thank you. I'm just going to share my screen. I do need to run a poll at the end of this, so I'd appreciate if you guys could just hang on whilst I share my screen, and then we'll do the poll just at the end. So just a few points. A few of you have seen these before. Let's have a little look. I'm just going to see if I can play this. There you go. Thank you to everyone who sponsored us for our OCL Charity Vision Run. You may have seen the videos that they put together on our social media, but it was a great cause, a great run. So thank you for all of you who did very kindly sponsor us. It was a good evening out. Hey, Allon.
Yes.
You all know about our referral portal. For those of you that are new to this webinar series, we do have an online referral portal, which is very safe, secure, and it reaches all the GDPR requirements. So if you go onto our website, at the bottom of every page, there will be a refer your patient. You can add very little information if you need, or you can upload scans, letters, whatever you'd like to do. So it's a very easy and safe way for you to send your patients over to us. Our specialties, as you know, we've got Ali Mirza, Allon Barsam, and Ramesh Anganawala, who all specialize in anterior eye, including laser eye surgery, lens surgery, corneal surgery. We've got Sally Amin, who you met recently, who does our glaucoma. And we've got our retinal team of Chen, Lorenzo, and Sharam. And then we've also got the lovely Susan, who does oculoplastics, who you will be seeing very soon next month. And just a small word on a dry eye clinic that myself and Kiva, the other optometrists, run. I know many of you will have this in practice anyway, but if you don't, we are always happy to see your patients who are suffering with quite severe dry eye that you've tried all the usual routine treatment for, and it's just not getting better, and they keep coming back and they're quite symptomatic. So this is a before and after of the Blefex that I did. I absolutely love the Blefex. So for any of you who are considering getting it, it's a fantastic piece of kit. We also have an IPL machine. We've got the Luminous M22, which in my opinion is one of the best machines out there, if not the best IPL machine out there. This is a lady who I saw recently, actually one of you referred her to me, so thank you for that. She came with a Schlesinger star that she'd had for some time, actually, that wasn't going down. She had a course of IPL treatment, and this is the result. So she was really pleased, and it works wonders. So if anyone has any patients that would like to send us to, please feel free to do so. I will take good care of them. This is our OCL Vision WhatsApp group. A lot of you are members already. The consultants post great case studies. It's a chance for you to ask any questions. There's a fantastic bunch of optometrists. So if you would like to join it, you can either email me on purvi@oclvision.com, or that is a QR code. So if you're watching on a computer, you could just scan it and hopefully it will let you join that group. I'll just leave that up there for about 30 seconds. I often get quite a few emails after saying you didn't leave it quite long enough. So I'm just going to leave it there for a little while. And finally, our next webinar is with Susan Srangapani, our oculoplastic surgeon, and she's going to be talking all things lid lumps and bumps, and it's going to be brilliant. I know it is. Often in time we see patients coming with little lid lumps, so we have no idea what they are. So she's going to take us all through that. I will send out the invite for you guys to register, or if you're keen and you want to register now, feel free to do so. Right, I am just going to load the poll now. I would very much appreciate if you could all fill in the poll. And as always, if you have any suggestions of any other webinars that you would like to hear about, please just get in touch with me and I'll see what we can organise. We've got Susan coming up next month, and then hopefully you'll get a chance to meet our newest surgeon, Lorenzo Motta, in the month after. And then I'll definitely be taking requests. So please hit me with your requests for any webinars that you'd like to know more about. Alan, is there anything you'd like to add whilst we're just running this poll?
Thanks everyone for tuning in.
I'm just going to give it another 10 seconds. Let's get all of you voting. Thank you. There you go. I'm going to leave it at that. So thank you very much, and we'll see you next month.
Bye-bye. Thank you.